Good day, everyone. I'm Dr. Benjamin Shu, Chief of Glaucoma here at the USC Roski Eye Institute. I'd like to thank the symposium organizers for the invitation to speak today. Before I begin, I'd like to acknowledge my funding sources, including the National Institutes of Health, as well as the Glaucoma Research Foundation. I do receive research support from Heidelberg Engineering, and I will be talking about anterior segment OCT imaging. Primary angle closure glaucoma, or PACG, is a common cause of permanent vision loss worldwide. The condition affects around 24 million people, which comprises a third of all glaucoma cases. The majority of PACG occurs in Asian countries, and the prevalence of the disease is expected to rise rapidly over the next several decades due to aging of the world's population. This rise in PACG prevalence is concerning as PACG confers a 2.4 times higher odds of blindness compared to primary open-angle glaucoma. In angle closure, there is contact between the peripheral iris and the trabecular meshwork. This impedes the normal outflow of aqueous from the eye, and when extensive, angle closure can lead to elevated intraocular pressure and angle closure glaucoma. Gonioscopy remains the current clinical standard for evaluating the angle to detect at-risk patients. The key anatomical structure to visualize on gonioscopy is the pigmented trabecular meshwork. When this structure can't be visualized, patients are told that they have angle closure and may be at risk for PACG. The importance of gonioscopy is emphasized by the preferred practice pattern guidelines by the American Academy of Ophthalmology. These guidelines suggest that gonioscopy should be performed in all patients who are suspected of glaucoma, suspected of angle closure, or who will be receiving incisional glaucoma surgery. Gonioscopic angle closure also forms the basis of current definitions of primary angle closure disease. Primary angle closure suspect, or PACS, is the mildest form in which there are two or more quadrants of angle closure on gonioscopy. This is thought to be a low-risk state for PACG. The next stage is primary angle closure, or PAC, in which there is also peripheral anterior synechia or elevated intraocular pressure over 21 millimeters of mercury. This is thought to be a high-risk state for PACG. Finally, PACG is diagnosed in the presence of glaucomatous optic neuropathy with or without visual field changes. Despite being the long-standing clinical standard, gonioscopy has a number of limitations. It is subjective and expertise dependent, and there's only moderate inter-examiner reproducibility even between trained glaucoma specialists. Gonioscopy can also be uncomfortable and time-consuming for some patients. We recently conducted a study to assess the utilization of gonioscopy here in the United States. In this study, we used data from the Optum database, which is a healthcare claims database that provides us with information on over 65 million insured Americans. In this study, we identified around 200,000 patients who were undergoing initial glaucoma evaluations between 2009 to 2020. Based on the claims codes in these encounters, we found that only around 30% of these patients had a record of gonioscopy within 6 months of their initial glaucoma evaluations, which is far below the recommendations by the American Academy of Ophthalmology. We also found that patients who were diagnosed with POAG were nearly tenfold less likely to have record of gonioscopy compared to those diagnosed with PACG, suggesting that some of these POAG cases could have been misdiagnosed. These data convey a major issue in the field of angle closure, which is that PACG often remains undetected and untreated until after severe vision loss has occurred. This figure shows the prevalence of blindness related to PACG based on data from population-based epidemiological studies conducted in Asia. We can see that in most Asian regions, the prevalence of blindness exceeds 25%. The rare exceptions to this rule occur in countries with better access to eye care and cataract surgery, such as in Japan and Singapore. Recently, my lab conducted a study in which we used data from the IRIS registry to assess PACG-related blindness here in the United States. The IRIS registry is an electronic healthcare records database that is administered by the American Academy of Ophthalmology and contains data on over 73 million patients. In this study, we identified around 49,000 patients who were newly diagnosed with PACG between 2015 to 2019. We found that among these patients, 12.4%, or roughly 1 out of every 8 patients, was blind in at least one eye at the time of first PACG diagnosis. This is despite high healthcare expenditures here in the United States. Therefore, there is an urgent need in the field of angle closure, which is the need for clear guidelines on who should receive treatment to prevent PACG-related blindness. Laser peripheral iridotomy, or LPI, is the most common form of treatment for angle closure. In LPI, a full-thickness hole is placed in the peripheral iris, and this provides a communication between the anterior and posterior chambers. This equalizes the pressure gradient, which has several anatomical benefits. LPI can lead to flattening of iris curvature, widening of angle width, as well as lowering of intraocular pressure in eyes with extensive angle closure. The benefits of LPI are clear in eyes with PAC and PACG. The landmark EAGLE trial published in The Lancet in 2017 showed that LPI provides robust IOP lowering in angle closure eyes with high IOP. We also know that LPI can break pupillary block and therefore acute angle closure attacks. The clear benefits of LPI in PAC and PACG has led to a consensus by both the World Glaucoma Association and the American Academy of Ophthalmology, who both recommend LPI for eyes with PAC and PACG in the absence of a visually significant cataract. However, we also know, based on population-based epidemiological studies, that the majority of primary angle closure disease is mild in the form of primary angle closure suspect rather than PAC or PACG. This leads to another important issue, which is that it is unclear which PACS eyes will benefit from prophylactic treatment. This was the topic of study of the landmark Zhongshan Angle Closure Prevention Trial, or ZAP trial, which was published in The Lancet in 2019. The ZAP trial recruited 889 participants who were bilateral primary angle closure suspects. All were between ages 50 to 70 and mainland Chinese. These participants were randomized to LPI in one eye and monitoring of the other eye. Participants were followed for 6 years, and the study endpoint was progression to primary angle closure, which was defined as the presence of peripheral anterior synechia, elevated intraocular pressure over 24 millimeters of mercury, or an acute angle closure attack. This table summarizes the findings from the ZAP trial. We can see here that LPI was effective in reducing the risk of progression by around 50%. However, the other primary finding of the ZAP trial is that even when untreated, PACS eyes were at low risk of progression to PAC at only 0.8% per eye year. The authors of the ZAP trial performed a cost-effectiveness analysis and determined that 44 PACS eyes needed to be treated to prevent one case of PAC, and 126 PACS eyes needed to be treated to prevent one case of PACG. These findings led the authors of the ZAP trial to conclude that efforts to identify and treat with iridotomy on a population basis probably are not the best use of resources. This conveys an unmet need in the field of angle closure, which is the need for a precise and reproducible method to identify high-risk PACS eyes that should receive LPI treatment. Fortunately, we now have access to OCT technology, specifically anterior segment OCT. ASOCT provides a convenient and powerful alternative to gonioscopy for evaluating the anterior chamber. ASOCT can produce beautiful high-resolution images of the anatomical structures in the anterior chamber in mere seconds. While these images can be assessed qualitatively, they can also be analyzed quantitatively. First, the cornea, iris, and lens have to be segmented, and then the scleral spur, which is a key anatomical landmark that sits directly posterior to the trabecular meshwork, must be identified. After this process, we can obtain measurements of various biometric parameters that describe the size, shape, and configuration of the anatomical structures in the front of the eye. A focus of my research early on in my career was to answer this question: are ASOCT measurements predictive of intraocular pressure and angle closure outcomes? This was a study that we published in Ophthalmology Glaucoma in 2018, in which we studied the correlation between IOP and angle configuration measured by OCT. In this study, we used data from the Chinese American Eye Study, which was a population-based epidemiological study conducted by USC investigators here in Los Angeles. We obtained ASOCT imaging on the majority of study participants using the Tomei Cassius web source ASOCT system. And in this study, our measure of angle width was trabecular iris space area, or TISA, which measures the amount of space or area in the angle recess. This plot shows the relationship between IOP and TISA measurements. We can see on the right of this plot, for eyes with wider angles, there is no relationship between IOP and TISA measurements. However, below a certain cutoff or threshold, there emerges a strong negative correlation between IOP and TISA measurements. This plot would suggest that below a certain cutoff, the risk of elevated IOP begins to rise. More recently, I collaborated with the authors of the ZAP trial to look at ocular biometric risk factors for progression of primary angle closure disease. In this study, we used data from 643 untreated PACS eyes to observe the natural history of PACS to PAC. And all of these participants had received gonioscopy and ASOCT imaging at baseline. Our outcome measure was progression from PACS to PAC. This table summarizes the baseline demographic and biometric differences between progressors and non-progressors. What we can see here is that progressors tended to have higher intraocular pressure at baseline. There was no difference in cumulative gonioscopy score, which is a sum of the gonioscopy grades across the 4 quadrants. However, there was a significant difference in both angle opening distance, or AOD, as well as trabecular iris space area, or TISA, between progressors and non-progressors. Specifically, progressors tended to have narrow angles at baseline. Progressors also had smaller iris area as well as flatter iris curvature at baseline. Next, we developed multivariable models looking at predictors of progression. In this model, we included AOD as our measure of angle width. We can see that adjusted for age, iris curvature, and anterior chamber depth, AOD was significantly associated with progression. Specifically, for each 10 microns smaller in AOD, the odds of progression increased by around 10%. We also developed another model in which we replaced AOD with gonioscopy score as our measure of angle width. Here we can see that gonioscopy score was not associated with progression, which informs us that ASOCT imaging provides us with unique information about angle closure progression that current conventional gonioscopy does not. More recently, we've conducted a series of other studies demonstrating that precision care with ASOCT in angle closure eyes may be possible. In this 2023 study, we identified that measurements obtained from ASOCT images in the light may actually be more predictive of progression compared to images acquired in the dark. We've also demonstrated that ASOCT measurements of angle width are predictive of progression in PACS eyes that have received treatment with LPI. We've also demonstrated that ASOCT measurements can predict the amount of angle widening after LPI as well. However, at this point, it's important to consider certain barriers to clinical implementation that might prevent us from adopting ASOCT imaging for angle closure care. One major barrier to clinical implementation is the fact that most eye care providers don't have the time or the expertise to manually analyze ASOCT images. As I mentioned previously, the scleral spur has to be identified in these images before measurements can be obtained, and this can be quite difficult, especially in eyes that have iridotrabecular contact or angle closure. Fortunately, we live in the era of artificial intelligence, or AI. AI is a powerful transformative technology that can help us automate aspects of clinical care and image analysis. This is a paper we published last year in collaboration with Heidelberg Engineering, in which we developed an AI algorithm that provides automated expert-level scleral spur detection and therefore quantitative biometric analysis of ASOCT images. In order to develop this AI algorithm, we used just over 4,000 ASOCT images, each with a scleral spur location that was provided by an expert glaucoma specialist. These images were paired with these X and Y coordinates in order to train a convolutional neural network, which is a form of AI. This plot shows the agreement between a reference grader and a glaucoma specialist in detecting the scleral spur. We validated the algorithm using a data set of just over 1,300 images or just over 2,600 scleral spur locations. We see in this data set the error by the second human, calculated as the reference minus the predicted scleral spur coordinates, was around 61 microns. This scatter plot shows the agreement between the human and the AI algorithm, and we can see that the scatter plot looks very similar, and the median error is similar as well at around 56 microns. This table shows the intergrader reproducibility of biometric measurements associated with those scleral spur locations. We see the agreement between the reference grader and the glaucoma specialist was excellent for all parameters with intraclass correlation coefficients exceeding 0.96. However, this performance was matched by the AI algorithm, which produced similar agreement with the reference grader. This data shows that the Antirion can produce expert-level biometric measurements with the click of a button. In summary, primary angle closure glaucoma is a visually devastating disease. Anterior segment OCT can identify high-risk angle closure eyes, whereas gonioscopy cannot. In addition, AI can help address shortcomings of ASOCT by making the technology more accessible to clinician users. However, more work is needed to overcome other implementation barriers and improve clinical outcomes for our patients with angle closure. I'd just like to thank you very much for your attention. If you're interested in learning more about our research on angle closure and ASOCT imaging, I invite you to follow us on social media, and I wish you all a very good day. Thank you again.